All right, everyone. Well, thanks again for joining. And my name is Denise. I'm one of the hygienists here at Shadlin's Pediatric Dentistry, and I'm also the clinical coordinator for Shadlin's ABC. So I'm going to just share my screen here, and we're going to get started with the presentation. Let's see. All right. Okay, so thanks again for joining. So today, Dr. Lopez is going to give a short snack size webinar of orofacial myofunctional disorders and pediatric sleep disordered breathing. So both of these subjects are a lot of information. So we decided to try to make a short webinar and just give parents more information about these topics here. And this is the agenda for today. And so about a year ago, we started doing exams on our patients for tongue ties. And after Dr. Lopez was really convinced by the research of how tongue ties affect sleep and all these disorders. And we really just want to be able to take care of our patients and families. And we had a lot of questions over the years. So we really just wanted to take some time to just go over how this affects children. And our biggest reason why is that we want to help identify potential issues early enough so our patients can keep growing healthy smiles and minds for healthy breathing and sleep into adulthood. So this is our main reason why we are really just taking more time to go over this more in detail with you guys. And these are some of the common questions we've received from parents over the last year, and some of the questions that Dr. Lopez is going to be able to address in today's webinar. And the other reason, that I wanted to go over this with you guys is with sleep disorder breathing, it really starts to affect children and their learning and things like that, because they're not able to get the deep sleep that they need when they're sleep disorder breathing. And then that doesn't let them have the release of the growth hormone that they have when they're in their deep sleep, which is a stage 3 REM sleep. So without further ado, I'm going to have Dr. Lopez over here and give you guys this snack size webinar. And if you guys have any questions at the end, feel free to email me at Denise at shadlins4kids.net, and there'll be more information at the end of this as well. And yeah, okay, I'm gonna have Dr. Lopez come on over.
Hi, thanks for being here. Denise is right. So basically I've been following sleep dentistry since I got out of residency in 2005, but it wasn't until the past few years, I'd say maybe 5 to 7 years, that I started to see research coming out in pediatric dentistry and sleep disordered breathing. And I finally was convinced by my brother coming to stay with me during COVID and realizing that he had issues that had been unaddressed. At the time, he was 28 years old, and we went to a myofunctional therapist in the area, and he ended up working with her, and eventually he did need some tethered oral tissue releases, and we'll talk a little bit more about that. And he told me it changed his life. So once he told me that, I was able to then tell my team that we were going to start talking about this. And for the past year, that's what we've been doing. So this is Dr. Joseph Gaudio, and he is on the East Coast, and he wrote this pamphlet and handout for parents. And you'll see here, because parents often ask why we're talking about this, and you can see all of the different reasons why here that you might worry about a child. Or an adult, to be honest with you, because even though we're addressing this from the pediatric standpoint, since that's our patient population, this can apply to adults as well. The traditional treatments, a whole list here for you to take a look at, and you'll see how all those treatments are not really addressing a core reason for the issues. They are actually just trying to address the symptoms, which is something that we are trying to move away from. So, what is sleep disordered breathing? It's a health epidemic. And like I just said, we're trying to get to the core reason of why these presentations are coming into offices and why people are feeling like they're not getting enough rest, why they're feeling so tired, having emotional disturbances, so on and so forth. And the main reason is that you've got nasal breathing and you've got mouth breathing. Now, we're meant to breathe through our nose, but if we can't breathe through our nose, our safety valve mechanism is to breathe through our mouth. And you'll see here, you can see the little boy here breathing with his mouth open. And if he has a stuffy nose, if he's got allergies, if he's got enlarged tonsils and adenoids, lots of different reasons that we'll go through. Breathing through his mouth, what he's doing is he's actually expelling more carbon dioxide than is normal. And in order for your body to be able to absorb the oxygen that you breathe in at a molecular level in the lungs, the carbon dioxide has to be exchanged for the oxygen molecules. So if you're expelling too much carbon dioxide, you'll end up with not being able to have enough oxygen in the system. And not having enough oxygen makes you tired. So sometimes parents will say to us, well, my kid sleeps fine. They sleep all night. And, when I had children and I start looking in on them before I go to sleep, I open the door, I glance in. If they're not moving, I usually just close the door and, don't wake the sleeping baby kind of thing. But since I've started to understand more about sleep disordered breathing, I now go in and actually take a look at how they're sleeping and try to help them learn better ways to do that. So on the right side of the screen here, you'll see nasal breathing, and the nose is specifically designed to take care of the air that comes into the lungs. So where mouth breathing, you have the air going in and out, through nasal breathing, you have turbinates that will warm up the air. You have filters, you have the little hairs, the cilia inside your nasal passages that help to clean the air. Once you get past that point, you've got an adenoid and your tonsils there, and those help to put immunoglobulins on the air so that once it gets to your lungs, it's clean, it's warm, and it's immunized. And at that point, your body can handle it better. Now, compare that to having your mouth open where the air is not getting warmed, it's not getting filtered, and it doesn't have any or not many immunoglobulins on it. So you're introducing that into your system, and it can become a vicious cycle.
So growth, because like Denise explained, growth hormones are released during sleep, especially during stage 3 sleep. We start to see kids who are chronically not getting the quality of sleep falling off growth charts. We've got kids who are failure to thrive, or just slowly, if your pediatrician starts to see trends of them falling off the growth charts, it might be a sign that something is not happening correctly. You have a high palate, so your palate is supposed to grow wide so that it can cover your bottom jaw. The top maxilla is the top jaw, and the mandible is the bottom jaw. Those are supposed to come together almost like a Tupperware, where the lid just barely goes over the top like this. But if you don't have your tongue sitting flush against the top of your mouth, which gives you the negative pressure that you need in order to draw the air in and out through your nose effectively, if your tongue, for whatever reason, is sitting at the bottom of your mouth for the most part, the pressure from the muscles of your cheeks and your facial muscles will start to put pressure on that jaw. So whether genetically speaking you're predisposed to having a high palate or not, you can create that situation by not nose breathing and by mouth breathing, so that jaw, instead of growing out, will grow up. And eventually that may lead to what are called cross bites in order to be able to masticate, which can lead to facial asymmetries and difference in the length of this is called the ramus here, where the jaw comes into the joint. It's called the TMJ, the temporomandibular joint. Sometimes those will grow at different rates because you've got a constant biting to the side. So you can see how all of this starts to cascade and lead to future events that may not be favorable for the child, including if you take a look at this photo here all the way to the right, you can see a retrognathic chin or weak or stunted chin. And basically what that means is that she's got an open mouth posture there. Her chin is so far back that her tongue isn't able to reach to the top of the palate. In order to make that possible, something has to bring that jaw forward. While kids are growing is the ideal time to do that, because once you stop growing, you're looking at really needing some sort of orthognathic surgery. The two pictures at the bottom show crowding that can also happen from not having the growth going in the correct way for the arches. And also, the tongue is meant to, when you're an infant and you are nursing, the tongue is meant to push out, because babies don't actually suck milk out of breasts, they actually express it. And so the tongue and the way that a baby uses their mouth are meant to press and express the milk out so that they can swallow it. If that swallowing action of pushing forward continues and never matures into going up to the top of the mouth with a backwards wave action to swallow your food, then they're constantly going to be pushing against those front teeth. And you'll see how that can create an anterior open bite there. So one of the doctors that I have been closely following and taking courses with, his name is Dr. Sarush Zaki. He's down in Southern California, and he has an institute called the Breathe Institute. You'll hear more about him in the rest of the presentation. And I'm a very visual learner. He is very conscious of the way people learn, so he presents the information in lots of different ways. And this tree shows some of those consequences, what long-term mouth breathing can lead to, including some that we don't really think about, like psychological issues, decreased quality of life, cardiovascular and pulmonary issues that are well known to be correlated to obstructive sleep apnea, especially in adults, systemic metabolic issues, neurological issues, because when you're developing, if you don't hit your developmental milestones, you can't then build on that milestone. So let's say you're an infant and you're used to pushing your tongue forward to swallow. If you don't learn how to put your tongue up in order to swallow, you can't then build on that. And so your neurological pathways don't continue growing from there. So there is some neurocognitive dysfunction that can happen. So this is Dr. Zagi, and this is his myofunctional therapist, Sanda Valku-Pinkerton. Both of them co-founded the Breathe Institute. And one of the things that they've focused their tenets of teaching is on tongue tie, tongue tone, and tongue space. So when we started doing our evaluations, that's what we look for when kids come in for their regular routine recall visits. And we're looking to see if they have any tongue ties or tethered oral tissues, what the tone of their tongue is. The tongue is actually 8 paired muscles on either side, so 16 muscles altogether. And the beautiful part about that is that the tongue can make so many complex movements by having all these muscles working together. So as long as they can and they know how and they've exercised it, they do all of this without attaching to any skeletal bones other than the hyoid bone. And the hyoid bone kind of floats in the back of your throat here. So everywhere else it's attached by mucosa. And so if the tongue doesn't have the strength to do what it needs to do, it just kind of sits at the bottom of the mouth. And you can see how that would put more pressure on all the other muscles and again, lead to a cascade of events. And lastly, so we've got tongue tie, tongue tone, and tongue space. And that is the issue we were just talking about how the palate grows and whether there's enough room for the tongue to do the actions that it's meant to. So in order for everything to grow the way it's supposed to, these muscles have to work in balance together and in harmony. So where are we looking? What kind of evaluations are we doing? The Breathe Institute has developed a protocol that was recently adopted by the American Academy of Pediatric Dentistry. So we have started using that here in the office as well. And it focuses on looking at nasal breathing, noxious oral habits, chewing and swallowing patterns, the resting posture of the tongue, lips, and jaw, functional speech patterning, head, neck, and body posture. And all of these will be important, and we'll kind of go talk about them a little bit more. In this image here, you can see how if your tongue is not strong enough to stay at the top of your palate, when you go to sleep, what you end up doing is having gravity pull back on those muscles. So after stage 3 sleep, you go into REM sleep, and that's where your body completely relaxes and your brain starts to do all the cleaning that it has to do. So all the metabolic waste that's created, the cerebral spinal fluid uses that REM time for you to dream, but also to clean out your brain. So if you've got your tongue falling back into your airway because of gravity and it's not sitting where it needs to, then you're not going to be able to breathe well. So a lot of people that have sleep disordered breathing will prefer to do either side sleeping or stomach sleeping rather than back sleeping because they can't get enough air while they sleep on their back. Okay. And then, if you understand obstructive sleep apnea, you know that eventually the body stops responding to that blockage of air and you actually become apneic, which is where you don't breathe at all. Now, this happens mostly in adults, and the sleep studies to test this have been developed for adults. So in the pediatric world, sleep studies can identify kids who have these issues at a very chronic level. But for the ones that have sleep disordered breathing, one of the worst things you can do is actually have a sleep study completed and have it come back as being negative, because then there isn't the impetus to actually see why it is that these children are having some of the symptoms that we see with sleep disordered breathing. Because a lot of times kids, if they don't wake up completely, it's called what's called nighttime arousals. So it'll increase the frequency of nighttime arousals, which means moving around a lot, not ever really consciously waking up, but coming up out of those sleep stages, kind of like this, instead of being able to stay in the stage so that the body rests. These are two other doctors. So Dr. Zaghi is an ENT surgeon, and Dr. Nordstrom and Dr. Tenholder are both general dentists, and they have approached this problem from a very similar way, but also looking at the cranial nerve system. So how are these cranial nerves involved in the reflexes that need to develop, and what happens if those reflexes don't develop? How can we help these infants, these babies, these adults get back online as far as their neural pathways and the connections are meant to be? So when we're looking at this, we do have an infant, what's called ACORN assessment. So that's the assessment of the cranial reflexive oral neurology of the infant. And we look to see where they are on the scale and what reflexes they've developed, so we can try to identify where along the line they kind of fell off. Now, why? When is this important? You can see this is another beautiful visual from the Breathe Institute. And you can see the baby over here with a pacifier. That's kind of when you can smell smoke. Moving to an elderly gentleman over at the side, which if you don't take care of the issue, by the time you're there, you're wearing a CPAP, or there's a new device for people with obstructive sleep apnea called Inspire. So instead of having that bulky CPAP covering their face every night, you have something similar to a pacemaker. It's a device that's implanted right in the pectoral area, and it connects to your hypoglossal nerve. When it senses that you aren't breathing, it stimulates the hypoglossal nerve to pull the tongue forward. And the people who developed the Inspire device are now doing research to see if they combine tethered oral tissue therapy and surgery, so TOTS is what we're talking about today. If they combine that with the use of this device, will that improve the experience for their patients? I don't know where my little fireman's badge went here, but you can see how in the toddler area, you start to see smoke. And growing up in Chicago in the Midwest, I'm not used to fire season, even though I've been living in California for 10 years now. It's still kind of always on the back of my mind. And you know that if you have a fire that gets to forest fire level, it's going to take a lot longer and a lot more energy and a lot more time to put that out. So if we can see the signs early, treat the signs earlier? Can we have better outcomes for once that individual becomes an older person? So here is Dr. Zaghi's protocol got accepted by the AAPD, as I mentioned. It's called the Ferris 6, and we are using this in the office for the older children. And they came up with this saying, tongue up, lips closed, healthy breathing through the nose. Something that we repeat to our patients when they leave so that they can remember: tongue up, lips closed, healthy breathing through the nose. It's fun. They like it. We repeat it. And we basically sometimes walk them out of the hall just singing that. So not only has the AAPD said, okay, this is an issue in the pediatric population, we are putting out the Ferris 6 protocol so that pediatric dentists in the country and around the world can see that we think this is important and have some help in identifying it. The American Dental Association put out a policy statement in 2017, which they updated in 2019, stating the role of dentistry in the treatment of sleep-related breathing disorders. So I've been following sleep medicine since I got out of my residency, actually my general residency, which was in 2003. And it's mostly been in the adult sphere for much of that time. It really isn't until the last 5 to 7 years, maybe 10 years, that some of this has been talked about in the pediatric world. So we're still learning a lot. And this is just meant to be, like Denise said, a little bite size of what is out there. Okay. Oops. So when we do assessments, we break it up depending on where the individual is. So the needs of infants, from infants to about 3 years old, and what we expect to see are different for kids over that age. Dr. Pinto, who's down here, she works with Dr. Zaghi at the Breathe Institute. She is also a general dentist who has begun treating only infants. And her picture here shows this little baby. If you take an infant, just this one's 5 days old, and just gently pull in its chin as it's sleeping, you'll see that if they're using their tongue correctly, the tongue is suctioned to the top of the palate. And that is where your tongue should rest anytime you're not actively speaking or chewing your food. So if you're not chewing, you're not speaking, your mouth should be closed, lips closed, tongue up to the palate, healthy breathing in and out through the nose. Okay. And one of the things to note with infants, their needs are very unique because they are new to this world and they just went through the trauma of birth. So it is a trauma, whether it's positive or negative, no one's making that judgment, but it is traumatic for the child to go through the birth canal, compresses their structures, and they have to decompress that by respiration, by movement. And if they're not getting that for whatever reason, or whether they didn't follow that through the birth canal and they had a C-section and were pulled out that way, their body may not recognize signs of what the neurons are supposed to do to get those reflexes going. All right. And so a lot of times for infants, this presents as troubles with nursing. So this is where we have lactation consultants sending people in for an evaluation of whether the tongue tie or the tethered oral tissue is restricting the tongue or not. The assessment for kids from 3 to 10 years old is a little bit different. Their tongues are more fully developed. They should have already transitioned into away from the tongue thrust swallow pattern. And you can see here, if you look at the top set of photos here, you see the tongue going up. That first grade 1 tongue, you can't really see any tethered oral tissues, but we all have them. Whether you can see them or not is one thing, and whether they're restrictive or not is another. Grade 2, you can see a little bit more, but nothing that looks like it's going to really impede that person's ability to function. Maybe it is. Grade 3, you can see a little bit more, and grade 4, you can see that the tongue is obviously restricted and not able to move around. So that tongue is probably not going up to the palate. So an important takeaway here is to note that the tongue function is due to the tongue tone, like we discussed, but it can also be due to the tongue tie. And so one of the things we have to do is a really thorough interview with parents or with individuals to find out what the symptoms are that they're experiencing, because what looks like a tongue tie in one person might not be a tongue tie for another person. It completely depends on the makeup of their fascia and their elastin and collagen and, you know, all of the things that the fascia is made up of. So that's where diagnosing off of a picture is not a good idea. Now we've got once you go past that first decade of life, we start to see some of the issues that present with more adults. A lot of that has to do with inability to focus very well, chronic facial pain, physical appearances that are not changing any longer, fatigue. And so this is when it would be appropriate for a sleep study so we can determine what is going on there. So what are orofacial myofunctional disorders in therapy? So an orofacial myofunctional disorder, or an OMD, is basically when all of these things are not working together in harmony. Something is off and we need to figure out how to get that back together. And the therapy for that is kind of like physical therapy for the tongue. Okay, we need things back into balance. And what we're looking at here are parents coming in with any of these reports for their children, or even adults. We've had adults come in saying that they have really difficult time gagging, that they are constantly tired, that they sleep a lot, but they're constantly fatigued. So mouth breathing, solid feeding, sleep disordered breathing, and neurodevelopment, we've kind of hit on all of those. Now, one of the things we haven't talked about is muscle compensation and head forward posture. So muscle compensation is when your tongue is not doing what it's supposed to do, your other muscles will come in to do the work for it. And if this happens over time, you can see that your head is actually really heavy. And in dentistry, we have an issue with forward head posture. So do a lot of people working in technology, or anyone who sits in front of a computer or on your phone or tablet. And for the same reason, your head is heavy. So if you're constantly pushing your head forward because your neck muscles are straining to help you swallow, then you're going to end up with this head forward posture. And you can see how that affects the spine over time. And lastly, speech. We're asking a lot of kids to say a lot of silly things when they come in for their exams, so that we can see if we can hear any sort of lisping or compensating going on with these sounds. And these are the typical sounds that you'd see that with. So there are also some cosmetic things. When this isn't caught, you'll see the grimacing at the top, the mouth squeezing to be able to swallow or to keep the lips closed. You can see asymmetries in the face. And, you know, some of these people here are famous and you may recognize them. Doesn't mean that you can't, you know, be successful in life, but are they as healthy as they could possibly be? Are they able to breathe in and out through their nose, or is this affecting them? You'd have to do a thorough interview with them. This is Christy Gatto, and she developed a lot of the orofacial complex, or she wrote this book, but she talked a lot about what it is that we're looking for when you're doing myofunctional therapy. And you'll see that at the bottom of her pyramid here is respiration. And respiration and the ability to breathe in and out through your nose is what made us decide to bring this into the office and to start addressing this with parents on a bi-yearly basis. I never know if that's right. Is it bi-yearly? Anyway, twice a year. Mm-hmm. So here are the goals of the therapy. We already talked about having everything in balance. And if it's determined by the myofunctional therapist that, yes, we've got tongue space, looks like it's in a good place, tongue tone looks like it's in a good place, and it really is a matter of needing a surgical release for whatever reason, then the therapy is necessary so that we can get optimal therapy done in what's called a functional frenectomy procedure, meaning that you can lift your tongue up in order to have the release done, and minimally invasive as possible. There are some who will do these procedures putting people to sleep, and I've come to the conclusion that we will not be doing that because you can't see exactly what it is you need to release. So breath considerations. This book by James Nestor was eye-opening for me. I think I posted it on our Instagram or Facebook when I started reading it on vacation. It's very easy to understand. If you don't have time to read, because a lot of busy parents don't, listen to it on audio book, but it goes through why it's so important to breathe through your nose and not through your mouth. And this isn't new. The history, it goes through a lot of the history. There are many traditions, including yoga, which I studied, and meditation and mindfulness, and a lot of different breathing techniques that address this. And I kind of took the TBI metric and changed it a little bit. And I like to say lips closed, tongue up, teeth together, in and out the nose. So it's important to have your teeth together as well to promote the growth in the correct manner. So I mentioned a little bit about the cerebral spinal fluid. And in this video up at the right, you can see kind of flashing. That is the rhythm. It's called the craniosacral rhythm, and it follows respiration. So the the cerebral spinal fluid, which is what helps the brain clean out the metabolic waste during that REM cycle, is produced during inhalation and it's reabsorbed during exhalation. So if that rhythm is impaired or prevented, you get a buildup of metabolic waste in the tissues that can lead to inflammation. ENT consideration, we've got the architecture of the nose. So one of the first things you look for is there a nasal blockage? Are there enlarged turbinates? Is there a deviated septum? Do you have reduced sinus spaces? Have oral bacteria gotten into those spaces? Are the tonsils and adenoids inflamed? What is causing the reduced airway space? And one of the products we've recommended for the kids who do present with some of that is not only to go have an ENT evaluation that could include scans and sleep studies and so on, and might include laser surgical intervention for that, but also this X-Clear, which is a nasal sinus rinse that includes xylitol, which helps to inhibit the growth of oral bacteria. And it is a naturally occurring product. They do have adult versions too. So we definitely say when you brush your teeth, clean your nose. And honestly, everybody should be doing that, but especially if you have problems breathing in and out through your nose. So looking at growth in traditional orthodontics would address tongue space starting around eruption of the first molars and all of the front teeth. And that tends to be around 8 to 10 years old. And some kids need that at that stage. But what if we identify it earlier? What if we can see that there's a tongue space issue? When do we start addressing that? Do we wait or should we start sooner? More and more, we're starting to see different systems come out to do that. And there's a whole list right there of different appliances that can be used to restore the balance of the space. Now, how did we get here? And I know we're over time, right, Denise? Mm-hmm. So I'm going to try to talk very quickly, but there's another book called Jaws. And, I think James Nestor references Jaws in his book. So it repeats some of the same information, but the biggest takeaway for me was that virtually all the evidence shows that the orofacial epidemic can be traced not to our genes. So this isn't something that because your parents wore braces or because your parents have obstructive sleep apnea that you're going to get, but it's due to changes in our culture, particularly to ones in how and what we eat and where we live. So how and what we eat has to do with, are we giving the forces of mastication enough time to be able to help develop the structures correctly? We know kids have to go and run around outside so that they can feel the stress on their bones, and the bones can produce growth hormone and they can continue to grow strong and healthy. The same is true for the mouth. But if we take an infant who's weaned from nursing and continue to give them mushy, soft foods that melt in their mouth or that require no chewing at all, you are not challenging those oral tissues and muscles, and it's leading to some sort of leading to dysfunction. Not some sort of, but dysfunction. So doctors John and Mike New out in the UK were a few of the dentists that started talking about this first, and they focus on forward development of the teeth and the jaws, along with correcting poor posture in order to help this develop. Big disclaimer here that this is not a typical view that's accepted by the dental, the medical, or the mainstream orthodontia. So it's been a little bit of a challenge trying to send patients in for early treatment for this because this is not something that the associations are talking about. Okay. Or maybe they are talking about it, but what they're coming up with is that it's not a thing. That said, let's talk a little bit about fascia. And the science behind it. And basically, we've known about fascia for a while, but we're still getting more research coming out. Dissections have proved a lot in the ability to get better dissections and with technology. And recently, the definition has expanded to not just provide support to the organs, the muscles, and the bones, but also to include the tissue that surrounds all the cells, all the nerves, all the joints, all the tendons, all the ligaments. So basically, fascia is a like fishnet that holds your body completely together. There are 4 different types of fascia, and those fascia, let's go to the next slide here. So you can see that if that fishnet lattice structure is nice and loose and lubricated and is healthy, it can move better. But if you're not using it, the hyaluronic, I can never say this word. Denise is trying to mouth it to me like that's going to help. The hyaluron that's the liquid within these tubules and around the fascia, if that can't lubricate them, what happens is it dries out. It gets cold and it dries out and it crystallizes. And that's when you start to get that tight muscle and you start to get limited function of whatever is in that area. The fascinating thing for me is that neurobiologists have started to recognize in psychotherapy as well that one of the responses to trauma is a kind of like freezing of certain areas of your body. And for people who have really high ACE scores, which are adverse childhood events, sometimes that can lead to them not really being able to feel anything in their bodies at all. And some of the therapies that have come up for PTSD and for trauma are called somatic therapies, which is where you get the body to release without necessarily having to relive the traumatic experience. And what that is all about is about releasing the fascia. The other thing that's come out of dissections is that there are different trains of the fascial lines. So we've got the deep front line that goes from the tip of your tongue down the front of your body all the way to the tip of your toes. So you can imagine if you've got a tongue-tie tether holding that tongue down, that restriction is going to pull on that whole train of fascia all down the front of your body, and it can lead to restriction that leads to kind of like a hunching. You've also got the lateral line that has the sternocleidomastoid and the neck muscles in it, and that also goes down past your ribs and intercostals, along the gluteus and down the leg. So all of this tension here, all of this restriction here keeps the rest of your body from moving as well as it could. So the 4 layers, the superficial, the deep, the visceral, and the parietal. We'll be talking, the superficial has been treated for a long time with fascial release, manual therapy for the most part, and some laser therapy. And the deep tissue, or the deep fascia, is really where we get some beautiful stuff happening with the lasers available now. So here are a couple videos if you want to learn more about fascia. Fascinating. They're little tubules, and because they transmit light, they can transmit messages that go back and forth from the brain to the body and from the body to the brain at the light speed. There's a fuzz speech by Dr. Gil Headley. He's out of Colorado. I think he's still there, doing dissections and learning a lot about what fascia is. And Dr. Nikki Mills is looking specifically at tethers in her dissection, tongue ties. And the previous thought was that there was a little band underneath the mucosa and that band sometimes comes up and it's in the middle. What she found through her dissections is that it's not a band, that it's actually the fascia that gets drawn up into the mucosa. And you can see and be here that there's a mucosal, so you can have a mucosal tether. There's C, where you have the mucosal and the fascial layer, and D, where you start to have some of the genioglossus muscles getting pulled up into that tether. So when we're doing releases, what we're doing in our office is if there's a B and a C situation that the myofunctional therapist has said needs a surgical release, a functional frenectomy, we will do B's and C's. The ones that are in the D range where you have muscle involvement in any way, shape, or form, we are referring that. We're very fortunate to have the very skilled Dr. Zaghi, who comes up to the Northern California area once a month. So we will refer those cases to him. Lasers, I won't go into that. I mean, I think I found my new love, and I won't go into the details here, but if you see the spectrum of visible light, we're working with the infrared lights in the ND-YAG and the erbium-YAG spectrum, and the chromophores for those, which is what they're attracted to and how laser technology works. For erbium-YAG, it's water, and for ND-YAG, it's pigmentation, so hemoglobin, and you know, they use some of those for tattoo removals and so on. So in our office, we have this, both of these machines here. We have the Lightwalker and we have the X-Pulse, both of them by Fotona. They are amazing machines, and the X-Pulse I just bought last weekend so that we can give better treatment for our little infants. It's a little harder with the top machine for the babies. So with laser therapy, what are we looking for? We're looking at low-level laser therapy, which is now called photobiomodulation, and high-level laser therapy that has been integrated into baby lace, oral lace, and laughter by Dr. Nordstrom, Dr. Tenholder, and also Dr. Amy Ludeman-Lazar. And I've been studying with all of them to bring this technology and these therapies into our office. And here we have what it does is it provides warmth to quote unquote melt the fascia. So take those crystals, release them so that hyaluronan can go ahead and start lubricating the fascia, and the muscles can glide more smoothly against each other. So if you're in myofunctional therapy, using this light therapy as an adjunct will help that myotherapy to progress. I don't want to promise that it progresses it quicker, but I think it's more effective. It also helps to strengthen those neurological pathways, especially the ones that have not connected the way that they ought to. There are two other things that this laser therapy can do. One of them is that it downregulates the sympathetic nervous system, and the sympathetic nervous system is that fight or flight. So it's that state of constantly being at alert. And a lot of focus has been put on this for people who are highly anxious to upregulate their parasympathetic system. And one of the helpers in this is the vagal nerve is really responsible for this. And if you take a look to the right here, you can see the yellow nerves going down. That's the vagus nerve. And if you see the orange, those are the cranial nerves. Okay, so we've got all of these nerves functioning together in the same area, and we're able to affect those with our high-level laser therapy. Then we can help that reintegration, bring down the fight or flight state, and help people to be more calm and more centered in their own bodies. The last piece, which is fascinating and is way a totally different topic, is that this therapy can also open what's called the limbic window, which are the reflexes that we have no control over. And this is very similar to somatic healing with psychotherapy and trauma, in that it can allow for release of that trauma and emotional healing without experiencing the event over again. So what can we do? I've trained with Dr. Amy Ludeman-Lazar. She's a pediatric dentist in Texas who has been doing this work. Dr. Giovanni Olivi, who is her mentor from Italy, and he is a physician and also a dentist. He's been working with lasers from the very beginning, I'd say. I don't know, Dr. Levy, if you're ever on here, or maybe next time I talk to you, I'll ask you. And Dr. Saruzaki. And like I said, Dr. Zagi is an ENT. And because there are so many areas that this can affect, what we need is an interdisciplinary crew. So I've listed some and actually have remembered that I need to add a few more to this. So we will be doing that for the future. And it looks like Oscar raised his hand. So give me a second. I think I'm almost done, and then I'll see if anyone has any questions that we can answer. So takeaway note is that the most common etiology of an OMD is lack of nasal breathing. If it's impeded, the body naturally accommodates to rely on mouth breathing. The long-term effects of that mouth breathing lead to changes of the natural resting position of the jaw, tongues, and lips that influences a whole host of other things. And with that, thank you. I'll end with a quote by Maya Angelou that a person is the product of their dreams. So make sure to dream great dreams and then try to live your dream. And literally, what we're trying to do here at Shadeland's Pediatric Dentistry with our Airway Breathing Center for Laser Therapy and Surgery is to help kids get back to sleep so that they can literally dream. Thank you. And I don't know